Yeah, I think that all of our speakers have been so powerful today. And yes, I find it easier to accept a challenge when I know that the person challenging me has made all of the decisions the same way, right? Like they have had to make these hard choices. That is so powerful. And our next speaker is no exception. So Dr. Rohn Rigby has helped patients with medical weight loss in Layton for more than 14 years. He brings a wealth of informed medical expertise in helping patients discover healthier lifestyles. As a weight management expert, Dr. Rigby knows that a lower BMI means a greater connection to personal wellness. 15 years ago, Dr. Rigby himself was overweight and ended up in the ER with chest pains. He decided it was time to take control of his life, so he committed to his own unique regimen of healthier eating and activity. But the most important part of this story isn't that Dr. Rigby lost some weight. It's that he's been there, like all of us. He's looked down at his belly and sighed in exasperation. He's drooled over a piece of cheesecake. He's gotten on the seat of his bicycle and pedaled until his muscles ached. He then began a journey that has led to hundreds of hours and many years of research to study metabolic health through diet and lifestyle changes. Dr. Rigby knows that with the right information and encouragement, anyone is capable of losing weight and improving their overall health. You might find Dr. Rigby outdoors biking or spending time in the park with his family. He wants to help every patient learn that a healthy lifestyle means more than just a smaller number on the scale. It can mean stress relief, it can mean better sleep, it can mean balanced hormones, and it can mean an improved human experience. It is our great honor to present Dr. Rohn Rigby.
Thank you. Hopefully I can figure this all out. So thank you for inviting me, and hopefully you guys are enjoying, and hopefully you've learned something, because that's what we come to these things for, is to learn maybe 1, 2, maybe we can learn 10, but if we can get one thing that's going to help us, hopefully you can incorporate to your life, then you can make some changes and improve. So that's our goal with this whole thing. Hopefully I can figure this out. Let's see. There we go. So my disclaimer is what we do in medical aspects. I live a low-carb keto/carnivore type aspect, so I live it. I'm the medical director of the Ogden Clinic Medical Weight Loss, which is up north from here. And then I have a podcast that I'm trying to put together. Again, like a lot of everybody, mine's little versus all these other ones, so some ideas. So, again, they've kind of told the story a little bit, but I'm going to expand it a little bit. So in 2006, I'm walking out of Davis Hospital, which is up north. Had just been in the hospital with chest pain, and they ruled everything out. MI, nothing like that. Figured it was anxiety. Part of the reason I was really concerned is I have a strong family history: diabetes, heart disease, dementia, cancer. I'm a ticking time bomb. I don't want any of these problems. And I figured I'm in my 3rd year of residency, and hopefully you'd figure somebody who's gone through medical school and somebody's gone through residency and spent hours spending time and sacrificing trying to learn these things, that you would have a better idea of how to deal with these things. And I was walking out of the ER, and the doctor had given me all atypical chest pain, so nothing to worry about. I think it's anxiety. Actually, I had just finished my ER rotation, and what we did in our residency is we'd work night shift, but in our 3rd year of residency, we still had day clinic. So I'd be up all night, go to clinic all day, and then I went home and I had 3 kids, so I had to be dad and a wife, and so it wasn't just like nothing against my other fellow residents, but they could turn it off and back and forth. I couldn't. So when I walked out, ruled everything out, they wanted me to do a chest test or a chest stress test and all that kind of stuff. But when I was walking out, the ER doc handed me on a piece of paper. That's what the post is there for. He goes, "I think you have metabolic syndrome." And I'm going, okay, what's metabolic syndrome? Wait a minute, I'm a 3rd year resident. We tell patients this, and I know the numbers, but he goes, why do you think this? And he goes, you're, again, a ticking time bomb with all these different issues. I'm afraid this is where you're going. So that was my aha moment. So let's start doing things. And again, that was me. It's kind of hard to tell with my son sitting next to me, who is now 21. So you can get an idea of how long ago this was. So it wasn't something just recently. It's something I had struggled with. And again, looking back at Dr. Linska's pictures, we had some of the same ideas. I was one of the shorter guys on the football team, but we're the largest weight-wise, so not a good thing going on. But again, like I said, why was I here? What could I do about it? Possible metabolic syndrome, and didn't know what to do about it. So with doing this, I started doing what we were taught to do, looking for, before I go there, I forgot this part. I figured I was a little bit more prepared than some of my colleagues, since part of my undergrad should have got me prepared for this. Part of mine was in health promotions. So living a healthier lifestyle, physical activity, looking at that, things that physical therapists do, athletic trainers, looking at life, health is an important aspect. I actually did more than most doctors. I had some nutrition training in undergrad and then a little bit in med school, and then in psychiatry. Key things that can help us deal with these metabolic syndrome aspects, but I figured I should have been better prepared. Not really. I turned back to what I had been taught in medical school, and especially in residency, is look for the answer in medications. Not what caused it, why we're there, what Band-Aid can I put on it? And that's where I started looking for. In my senior year of my residency, I had to do a senior project presentation similar to this, not as many people, but that idea, and I did it about weight loss, looking at the medications, looking at the traditional food pyramid, incorporating exercise, all things that we've been hearing about today, and I go, that's all we've got. Well, unfortunately, we always look at medications, and if you look in the history, medications have been put onto the market and then taken off the market because of problems. Another one's come on the market, come off the market. So obviously medication wasn't the answer, but that's where I kept looking because that's what we were taught to do. And when we get in the medical field, as all of us have talked about, and those in the medical field, we talk either synonyms or short terminology. But a lot of times we'll use the syndrome, a collection, the technical definition, a collection of signs and symptoms that can lead to a problem. It doesn't give us the cause. It's just things that we should be looking at and piecing together, because you might have this part and this part and this part or this part, but they weren't. None of those four parts were bad enough to be able to treat. So using that, looking for answers, searching, asking for colleagues. When I got out of residency, asking the group that I joined, doctors have been practicing for a long period of time, what do you do? Their typical answer is put medicine on it. So I delved into it and I came across what a lot of you might have heard of as Syndrome X. And that came from Dr. Revens in 1988. He was the head of one of the endocrinology departments. He was receiving they call the Banting Award because of Banting, because, if I remember right, because of the whole discovery of insulin back, all that kind of stuff. But he kind of was looking at all the research that was going on with these different things and labeled it Syndrome X. And if it look at the screen, obesity, high blood pressure, cholesterol issues, and insulin resistance. But he didn't give us enough information, so we had to dig farther. So again, now we get called metabolic syndrome. What is it? It's a collection of those things. And we're going to delve into that a little bit more. But in looking and with time, I needed eventually to go, okay, here we go. The metabolic syndrome. So we're going to look at in each individual aspect. Okay? you have to have 3 of these 5 things. And I'll give males and females when we get to each individual. So you have to have 3 of 5 things. And if you ask most doctors who don't work in this realm or the low-carb, keto, metabolic health, any of them, they're not going to, that's not that big of a deal, I won't worry about it. But with blood sugar, above 100 in a fasting state. Again, our lab at mine, 106 is considered normal. Again, technically by these numbers, less than 100. Waist circumference in males above 40 inches, females above 35 inches. Your blood pressure, again, if you remember, we've said it was 130 over 80. Actually 85, sorry, 130 over 85. Again, no doctors, they're going to go, oh, you got some, we need to be watchful, maybe start doing it at home, but nobody's going to go put you on medication for it. HDL, again, for males less than 40, females less than 50. Again, if you look at the labs, if you remember looking at your labs, it always says A1 kind of range. And last but not least, your triglycerides, above 150. Kind of thing, ironic, I think, at least in my opinion, with metabolic syndrome, we don't talk about LDL. We always talk about cholesterol and LDL, and Dave does a great job with all the information, all the aspects of it. But when we have this metabolic syndrome, which can have 85% of the general population has, LDL is not part of it. So keep that in mind. So it was in 2012, I actually had, you'll hear from him later, Dr. Westman. I actually decided to go to a conference, again, looking for CME, getting interested and wanting to fix the obesity problems. Actually, this is my 10-year anniversary. I was actually looking at a conference that Dr. Westman was actually teaching at, the American Society of Bariatric Physicians, which they've changed the name now. But he was talking about what he's done, where he's gone, what his research he's done. And when I was listening, I was like, wait a minute. This sounds like Atkins. I still remember telling my dad, and it wasn't exactly, but I still remember telling my dad, this expert who took nutrition in undergrad, that he was hurting himself. Even though he had lost weight, he was coming off medicines. Me glorified college student, knew what I was talking about, told him he was hurting himself, and it was the wrong thing to do. We were taught it was a fad diet. Nobody taught me the history of it until I went and listened to Dr. Westman talking about some of the aspects and all the people up to that point. That got me going down a rabbit hole, which most of us have done. Most of you will recognize this is Gary Tobbs, who is an investigational reporter. I have a hard time with that word. And that got me digging into his books. And I put it in the order that I read them. It's not the order he wrote them when I read them. Starting with the shortest one, Why We Get Fat. To look at the history of why we got to there. Is jokingly, if I remember him saying, at least one time I heard him speak, this was his Cliff Notes version of good calories, bad calories. So if you want a lot of good research, great books, a lot of information, looking at the history of what got us to this point. Again, sugar, and then the most recent one, A Case for Keto. If you haven't read any of them, highly recommend any of those books. But that got me digging even deeper. Well, the whole idea of fat, that kind of stuff. That got me into thinking about the history of Ansel Keys, and most of you have heard of him. I don't know, I'm not a researcher, so take this for what it's worth. Most researchers will screw up a lot of things, but you have to admit when you realize you screwed up. Unfortunately, some of us can't get away from it. And sometimes when you have a set idea, you go and prove what you were looking for. At least from my understanding, that's what he was kind of looking at. He was trying to prove what his thought process was. We have more technology, we have better skills, understanding now. So not putting him off the hook, but that was one aspect that kind of got us going the wrong direction for a while. And then this quote by Dr. Atkins, again, if we went back and looked at the research, understanding how the body works, understand there's multiple fuel systems, we should understand this. Let's go look at the history and things. That got us into, most of us have probably read The Big Fat Surprise, how the importance of fat, all the different bad research that kind of got us, again, looking for what we want. And again, multiple people have talked about Dr. Ben Bickman down at BYU, so not far away, great book, looking at the insulin resistance. So different researches got me going down that road. Sometimes you can go look at studies. Sometimes it's better to read it from somebody who's outside of it looking in. We get a different viewpoint. So let's go back to metabolic syndrome. Just kind of a rehash. I like the picture, how it put it all together. We talked about the triglycerides and the low HDL and the high blood pressure, but the visceral fat, the waist circumference. But one key aspect was the insulin resistance. We always listed it, and if you look at the World Health Organization, they actually, to fit metabolic syndrome, you have to have insulin resistance. But even up to this point, outside of Syndrome X, nobody really talked about it. And you asked a lot of doctors, they go, oh, insulin's just to control diabetes. That's what we get taught. Unfortunately, you guys probably know more than they do when it comes to that part. But why? Why were we going this direction? What was leading us down this road? And if all these different aspects, we've got to figure out what we need to do to solve the problem. So getting back to, we always talk about all these different systems, and the human body is think of it as a system of systems. So all these systems are communicating, and we have regulatory systems, and again, a lot of times we'll call it the endocrine system that regulates it. But the key factor, all these things are trying to keep things in balance. And the term we use in the medical world is homeostasis. That balance of everything, the blood pressure, the cholesterol, the insulin, your GI system, your cardiovascular, we're trying to regulate these things. Always constantly balanced. But if our body's trying to fight it and something's getting out of whack, what is one key factor that's getting us to that point? Sometimes I like the cartoons. Basically, if 50% of the people are obese, I'm just overweight. I'm not overweight, I'm average. So again, unfortunately, we're getting to that point that a larger number of people are gaining weight. We've had numbers over and over you've heard today. It's not always just about the weight. I always tell my patients, it's what's making up the weight and where is it located. So it's not just the number on the scale. So again, when we talked about when you get frustrated, the number on the scale isn't moving. Great. But how do you feel? How do you function? What's your lab results? How are we sleeping? What's our emotional levels? And we're going to delve into that a little bit. So again, just kind of an idea, and all these different systems, and it's not just one system, from the cardiovascular, the brain, the heart, the lungs, the liver. We just had a great talk about the GI system. All those different aspects, how the pancreas plays a role, the female reproductive. We had a great talk about where women are in their cycle, when they should be incorporating some of these tools, when they probably should hold off on some of these tools. Just because we can do something doesn't mean we should do something, but we want to fix the problem. So just to kind of rehash on, we always talk about insulin. What does it do? Well, it helps regulate the blood sugar. It does lots more than that, but that's kind of the key thing that we're known that it does. It helps regulate the blood sugar. It helps get the sugar out of the bloodstream and into the cells, be it the adipose cells, the liver cells, the brain cells, the muscle. And again, yes, incorporating physical activity, which we'll talk about in a little bit, can definitely help after you have that higher sugar kind of component, or if you don't feel good, to help use up that sugar. But it just kind of gives you a global idea of what insulin, kind of a global review looks like. And unfortunately, from the weight perspective, we know there's multiple hormones, not just one. Insulin's just one of the growth hormone aspect. So just a simple picture, kind of looking at the yellow component that fits into the one receptor, it's the insulin, that now opens up the cell to get the glucose out of the interstitial blood supply into the cell. That's what kind of insulin does. So we get it in the cell, now we can use it in the mitochondria. Again, we've had great talks about all that different stuff. That's kind of the aspect of getting insulin into the cell, or getting sugar into the cell. But now we're talking about insulin resistance. So how's that? And there's kind of two theories or two mindsets when it comes to this. One is that receptor or that key is a little rusty. So it doesn't respond to the insulin. So what happens is our body has an elevated sugar. So what does it do to correlate or to compensate for that? It makes more keys. And insulin is the key. So it makes more and more and more keys. But if that communication doesn't work, we just keep making more and more. But one key aspect is not every cell has the same insulin resistance and or sensitivity. So we go, oh, everything is all insulin resistant, or everything's all insulin sensitive. No. Every cell can respond different. And like it was discussed earlier, your levels can adjust throughout the day. So keep all that in mind. Other way of looking at it is, again, not a good picture, but kind of the idea is trying to jam more into, and your body it's so overpacked with those cells that it makes less and less and less receptors to get the sugar in to the cell. If we stop putting the sugar in, we don't need as much insulin, and those cells can start responding and actually using some of that stored energy to be broken down and be released into the bloodstream. Again, pictures that are out there, kind of the idea, unfortunately, and doctors get so wrapped up in looking at your average blood sugars. Most of you have gone in for your general exam. They might have asked you if there's a family history, or they're concerned, or you asked for an A1C, which is your average blood sugar over the last 3 months. You check it, it comes back normal. And you're going, how can that be? Because it can go for years with good A1Cs, which is great. But where nobody's looking at the insulin. How much insulin are you having to produce to control the blood sugars? But if you look at the labs, again, the labs are just looking at a group of people and figuring out an average range, going back to that whole bell curve aspect. As long as we can get so many people under the bell curve, that's what normal range is. No. There's been numbers thrown around today, less than 6. I might be a little bit more specific or a little bit more aggressive. I like it less than 5, but it's just a number. We're trying to get that down. Now, can you still have some insulin resistance if those numbers are low? Yes. So keep that in mind too. But it takes time to get there. Some would argue 5, 10, I've read even up to 15 years. So it's not a quick fix aspect. Another easy way of looking at just kind of that, don't eat the greatest carbs, makes more insulin, cells become receptive, can't get it, have more storage, you feel tired, fatigued, so you eat more. It's just kind of that vicious cycle that we're trying to break. And unfortunately, those would be what's going on inside your body. But it doesn't always present visually. So some of these things that you might have symptoms that just the idea of different conditions and different aspects being affected by it. Unfortunately, we always talk about calories. Calories in, calories out. I know you guys don't, but just in general, that idea. And that's what we get taught about. So what is a calorie? This is Wilbur Ashwood, if I remember right. I forgot my notes. But back in 1896, was an experimenter and trying to understand what the components of the food or the energy from the food. So he built a machine, i.e. a bomb calorimeter, to understand how much fuel is being given off from these foods. And again, this could be very controversial. So our body doesn't know what those calories really are. All they know is what the end product really breaks into, and now how is that going to affect us hormonally? That's the way I always look at it. So if we always focus on calories, and if you guys have learned and doing a lot better, we got to fix more of the insulin. If insulin resistance is the problem, that's what we got to fix. And that's what we should focus on. Fixing the metabolic health. And that's where my focus and trying to understand and fix that metabolic syndrome or metabolic health is what we're trying to do. And trying to different ways of looking that things have been discussed in multiple different ways today, but we're looking to try to help not just weight, but also your overall health, your blood pressure, your cholesterol numbers. I don't know why we always go back to cholesterol, but those aspects, what can we do to improve that health, to improve the quality of life, to be able to do the things that you want to do? It might not be just about losing weight. It's more of have less joint pain. Or a lot of patients will be referred to me so they can get their weight down so they can have their knee surgery or their back surgery, or to help improve those things. We want to improve their overall what's making up the weight aspect. One key factor that we're all different about is our why. We've talked about it before, but part of it is you as an individual, you need to determine why you want to go on this journey. Because your journey is different than anybody else in this room. It might be, I'm tired, I'm fatigued, or me, I've got a horrible family history and I don't want any of it. So I'm trying to do everything, but everybody's why is different. So when you're working on these things, don't worry about everybody else. I know it's easy. We want to compare. We get Facebook, we get Instagram. We look at all their quote-unquote best, but they're not you. We had the discussion about males and females are not the same. They're not. And everybody else is totally different also. So understanding why you want to go this direction is a key factor. Another key factor before we get into this is understanding your age. The older we get, the more the slower our body heals. If you ever talk to a doctor, they go, oh, a break should take 4 to 6 weeks. The way I look at that, somebody's young on the 4, somebody older should be 6, and sometimes even longer than that. So the more experienced, I always hate the word age, but the more experienced you are, or more trips around this earth you've been on, the longer it's going to take to heal that. So keep that in mind. You can't compare yourself, if you're in your mid-50s, you can't compare yourself to somebody in their 20s, even if you're a male, and without all the other hormones that we talked about. Does that make sense? So that's another. So your why, your age. Now here's another key factor. Look at your family history or your medical history. If there's history of blood pressure or family history of it. Cholesterol, which we talked about. Waist circumference, which we talked about. Blood sugars, highs, lows, hypoglycemia, hyperglycemia aspect, where we are, we don't know. Again, inflammation, joints, skin. We talked about the gut health, all that. Everybody's different. History, depression, anxiety, attention aspects. Each of these, we can have a whole lecture on all of them. Chronic fatigue type issues, sex hormone abnormalities, eating abnormalities, history of PCOS or polycystic ovarian syndrome, infertility, males or females. Again, key factor. And history of diabetes. I did all that list and we finally got to diabetes. Now again, kind of the idea of in this environment, we like the low carb keto / carnivore. All can help. Part of it is being willing to work on, as it was discussed earlier, putting the right type of fuel in your body or into your vehicle. Okay? So I always go back to the basics with my patient. I say their body needs 5 things. If I take away any of these 5 things, they're going to die, and that's not my goal. One is water, obviously. One is air, because if I take away those, they're dead quick, and we don't want that. Protein. You've heard a lot about protein and avoiding and making sure you're getting adequate protein, because most of us try to avoid it. Healthier fats, which we're a lot better with that, and then micronutrients. So obviously, we've got to focus on that, and this is just kind of that idea, trying to find that combination that works for you. So the way I go with my patients, and a lot of people go, all you want patients to do is keto. No, I'm trying to find what's going to help them. And our dietitians will, because I never bring up keto in it, but when they see our dietitians, they'll come back and go, all you say is do keto. I go, I never bring up the word keto unless they bring it up aspect. And they go, but he says, all I have to eat is meat. And I am a big meat fan, so don't get me wrong. No, I said you need protein. So if it is more of a plant-based, great. You just have to mix and match and know what you're doing with it. If you don't do well with meat, great. You still need the amino acids. It's not about just eating meat. I'm a big fan of it. You need the amino acids. Second, the healthier fats. All the more the natural fat. And then the micronutrients, the salts, the minerals, that kind of components. So again, just the idea to remind us of that. We've talked about fasting, the importance, requirements, time, whatever. People go, how long do I have to go? Well, everybody's different. Find what works with you. If you're eating 5 to 6, 7 times a day, can I limit it by 1? If you're eating 6 times a day, can I get it down to the basic 3 times a day? And you go, well, I'm not a very good person because I don't eat breakfast. Well, technically you do, because no matter when you eat, for the first meal of the day or every other day, it's breakfast, but that's my technicality aspect of it. But it's being mindful of it. And again, going back to eating when you're hungry, not because you're bored, you're stressed, it's time. Again, is it the best way for everybody? No, it's a tool. So time restrictive eating, being mindful, but again, it's not just limiting the time or the going longer, it's what you eat when you do eat it also. And incorporating water. We all need water. We can talk about all the different numbers and the proper amounts, but again, we're all totally different. And that's part of the reason we gave you a water bottle today. Salt, one of the micronutrients, is a key component. Yes, we're a big fan of Redmond. Yes, it was fun to go down there. If you ever get to, go down and see that. But again, we need the salts. But we also have to be mindful if you have a history of eating abnormalities. Has it been brought up before? Do I think this can fix it? Yes, it's a tool. But you've got to be mindful about it. Not just, oh, I have to eat all this stuff. Will you do well with it? No. Or you're going, if I say you have to eat less, and go, but that triggers me to never eat ever again, or have anorexia, or I'm fearful of that stuff, or the binge eating aspect. You have to be mindful of it. There's a lot more in depth on all that, but you've got to be mindful about why am I eating? What am I eating? How much am I eating? The idea of chewing 20 times is great. Find the tools that are going to work for you. Look, part of this discussion or part of this idea is constantly keep learning. Because when you stop learning is when you stop growing. As a person, not growing this way, but growing as a person and improving the skills. But you have to be mindful of it. Again, which is better? Exercise, diet, good discussions, depends on who you come from or who you want to talk at. Exercise is both exercise and eating is beneficial. I always take the idea of putting the right type of fuel. So let's focus on the right type of fuel first. But again, we want to do some exercise. And unfortunately, a lot of people will want to go to extreme and think they got to do something like this. And going, I can't keep up with all those heavy lifters. I can't do these guys. No, great. Start simple. Start with where you're at. Do what you need to do and push yourself a little bit. Not what I can do. Not what somebody else can do. Where are you at? Where are you? And what can we do to improve it? But unfortunately, when we talk exercise, this is where a lot of people go. I have to go to extreme. No. Let's go simple. Now again, yes, anaerobic or the resistance is always better. And again, I agree when they say start with where you're at. So it might be walking. So walking into fast food. Do I endorse fast food? No. But if that's a starting point and that's where you're willing to go, start there. Because everybody's journey is different. Sleep. We've talked about all the benefits. Yes, you need it. I would actually say, I want you to focus on your sleep before you incorporate the exercise. Because if you're now sleeping better, You're probably making better dietary changes. You also feel better, therefore you have more energy to go exercise. I always tell my patients, don't sacrifice your sleep just to go to the gym. I want you to go to the gym, don't get me wrong. But if you're so time constrained, focus on sleep. Again, well, everybody's a little bit different. Yes, the recommendations, have a good go to bed time, get up time. If you have a hard time getting your brain to shut down, get off the computers, TVs, Facebook, all that type of stuff. If you can't, if you have to work, using blue blocking glasses, all that can definitely help. Avoiding caffeine too late in the day. Again, alcohol later in the day. People go, but I use it to help me sleep. Nah, not really. Nicotine also. Meditation, relaxation, and everybody's different. Again, getting sun exposure early in the day, definitely key thing to help the sleep cycle. There we go. And exercise. Stress management. Again, we can have discussions on what to do, how to do it, all different ways of good stress management. I look at stress a little bit different. I came across the discussion in a book at one time, and it was described in two different ways. We have distress. I don't like my boss. I'm having a hard time at work. The kids are driving me nuts. Financial reasons. Things that I don't really have control over. Then there's eustress. I'm not saying this is fun, but the idea of excitement about learning new things, trying to do something. I've got a business idea. I've got to do this and this and this. That's a eustress. Focus on trying to incorporate more eustress. That can help us incorporate doing these things, to make the changes. Try to avoid the distress and focus on the things you have control over. Worrying about things going on in the world that you have no control over isn't solving anything. It might make you feel better because you care, but worry about you. Find something that works for you. Again, habit loops, incorporating different habits, all these different aspects. There's lots of written on it, but a cue, the craving. If you want to break a habit, pick one aspect and change it. If you're trying to incorporate a new habit, make it obvious, simple, easy. We don't like hard things. The more we do, the easier it becomes. Start simple. There's the idea of, some books will call it, or some ideas as you anchor it to something else. Or habit stacking, either way. But a lot of people with the idea of meditation, people go, I know I need to. Great. If you get up in the morning, and I don't drink coffee, but a lot of my patients do, they go, if I get up in the morning, I go put on my coffee, great. Odds are it's going to take a couple of seconds to minutes. Can I relax and meditate? I had a patient who's going, I can't find time to exercise. Great. Odds are you take a shower. Yeah, every day. Great. Turn on the water while it's warming up, get down and do plank for a minute. Count to 30. Start simple. Start attaching to something you already do to make it easier to remember so you don't have to think about it. The brain uses a lot of energy and it doesn't want to. It wants to make things as simple as possible. So creating those habits, easier said than done. Willpower. You got to have more willpower. Part of it is changing your environment so you don't have to use it. So again, donuts are one of my weaknesses, or at least it used to be. Me going to the break room where they bring donuts, not a good idea. When a drug rep comes in and goes, what do you want for breakfast? At one time I would have said donuts, whatever the staff wants. Now I say whatever the staff wants because I'm usually not going to want it. Try to change your environment so you're not having to, quote unquote, say no or change things to make it easier for you. Again, we've had great discussions about the importance of the microbiome. Looking at how to change that environment to the bacteria that's already there, that's supposed to be there, the ratios and stuff like that. But also prebiotics. Prebiotic, that's where fiber comes into play, is a key factor to feed the bacteria. Think of a probiotic as you're actually seeding or putting the right type of bacteria in there so it can grow. But again, if you go out to a garden and you seed all the time but don't do anything else, nothing's going to grow. You've got to weed it by getting rid of some of the things. You've got to nourish it, and that's the prebiotic, and water it. So all key factors. We talked about CGMs, basically continuous glucose monitors. We had great discussions on that. Gives you a tool to help. Ask your doctor if you want one, to get one. If they go, you don't need it, your insurance won't pay for it, they might not. Get a prescription. Do it. There's different ways out there. Or ketone monitors. Keto Mojo's here. Again, the good and the bad of these things. Again, I love them. I think they can help. The problem is we only look at one. You have to look at both, in my opinion, to kind of get an idea what's going on. So if your blood sugars are low, or your interstitial fluids are low, and your ketones are low, that tells me your insulin level's high. We haven't fixed the problem. If your blood sugars are high, obviously we know the insulin level's high. But if your blood sugars are low, your ketones are high, that tells me your insulin level is lower, we're going in the right direction. So again, looking at both of these things to figure out where and what are things that actually do affect it. And the first time I wore it, I went for a run and I was like shocked. And even though you hear all these things that, oh, exercise bumps it up. I was surprised how much it bumped mine up. But how well it came down after I exercised too. If you're on medications, this is one thing doctors don't talk about. What are we doing to make it harder for you? I understand why they're doing it. They're trying to solve a problem. No doctor is out there intentionally trying to hurt you. They might not be trying to fix you the right way, at least in our opinion. Does that make sense? But they're not intentionally trying to hurt you, but the medications have problems or potential problems. Unfortunately, a lot of times we look at the symptoms, the cause, but when we put you on medications, we're putting a Band-Aid on. That's all we are. It's not solving the problem. It's not getting to the cause. Just a Band-Aid. Another Band-Aid. Another Band-Aid. Another Band-Aid. And then we go, we're being over pharmaceutical or pharma. Yes. Trying to speed things up because we're almost done. Sorry. Labs that again, my patients will say I do a lot of labs. In fact, the lab techs hate it. They call it the Rigby patient because I do a lot of blood work, but I'm trying to figure out what's going on to understand what's part of this underlying issue. And looking at medications, not what's making it worse, but what are some tools that you can do. If you're doing all these things and we're not seeing the benefits, you're going, I don't know where else to go. That's where sometimes supplements can definitely help. Just simple ones. But I got this from Dr. Ballester that he did in one of his things I saw online. I like it. I am a doctor who can write prescriptions for you, but I like these meds better. There's a tool. Meat, eggs, dairy, seafood, if you do well with those things. Obviously, avoid something you don't do well with. But trying some overall tools that can help, just some different things. Focus on your why. Don't compare yourself to somebody else. Remember where you are on this journey. The diet, fasting, timed eating, all good tools. Exercise, great. But I also take the idea you cannot run a bad diet, so let's go fix the diet. Working on your sleep, stress management. But then there are other tools. Understand it's going to take time. That's one thing I always ask my patients. How long did it take you to get here? If they said 10 years, great. Jokingly, I go, I get 20 years to get it off. And people hate it when I say that because we've got to fix the metabolic syndrome or the metabolic health. And it takes some time. And some of us don't heal as quickly as others. Willpower, gut health, just different tools. Now again, since I do it in obesity medicine, just different tools that are out there. I know it's not just about obesity. There are tools to help. It's not about using medicines, but part of it is being able to have an understanding of what the old ways were more of trying to make you just not hungry. Now they're starting to use a little bit more medication, and from hunger to cravings to trying to get the gut microbiome or the gut health, that some hormones of your gut can be part of it. And again, there are some non-FDA approved medicines that can definitely help with the weight. But again, we're trying to fix the metabolic health. Again, using the idea of a fuel. If this was your car, you're probably going to take a lot of time and effort to take care of it. You're not going to leave it out in the rain or the hail. You're not going to put whatever fuel, whatever. You're not going to go cheap, whatever. This vehicle is more important than that vehicle. My call to action is for you to look at your life. Take some time. Figure out where you feel like some of the weakness areas are and focus on that one little thing. Start with what you need to do. Do what you need to do. Then start with what's possible. And all of a sudden, the impossible things that you think now will start becoming apparent, or you can do it. So again, my journey, there's that. So I understand it, struggle. Again, information, again, why wait? I'm all done, but I'm going to go here really quick. Just a new beginning. My goal is to help you soar. This is our logo for our podcast, just as a phoenix arising from the dead type idea. And small and simple changes can make into big changes. Thank you.